Good afternoon. So we're just going to get started on the post-lunch session, which is on post-injury care and trauma care in low and middle-income countries. My name is Asad Latif. I'm an assistant professor in the School of Medicine in the Department of Anesthesiology and Critical Care. I'm also a faculty member at IIRU and focus on working with the injury unit on burns injuries internationally, and not only the epidemiology of burn injuries, but also the in-hospital and post-care of these patients, and also with Dr. Stevens, focusing on quality improvement and adherence to best practices in these post-injury patients. The topic at hand is, in my opinion, a crucial one as a physician. We're moving on from just looking at the hows and whys, but also to what we actually do about patients once they've been injured. I think is a crucial next step in treating them. So with that, I'd like to introduce Dr. Ken Stevens, who's going to talk about trauma care in low and middle income countries. Dr. Stevens, as most of you should know, is the associate director at the injury unit and a colleague of mine, also an assistant professor at the School of Medicine in trauma and critical care, acute care surgery. And with that, Dr. Stevens.
Sorry for that. Sorry, I'm a Mac person, so I'm always confused. It's over here, right? Yeah, thank you. All right. Sorry about all that. So this afternoon, I'm going to talk about trauma care in low and middle-income countries. I'm going to do kind of a broad stroke. Daniel and Guru Raj will get into a little more detail about the specifics in each of their countries. But I'm going to do a broad sweeping, just talking about trauma care in this setting, and intermixed with a little bit of what happens in the developed world with injured patients. I'm going to review the trauma care system components for those of you who are not familiar with trauma care, and that's specifically how it works in the developed world. I'm going to talk about the benefits and impact of trauma care in general and what we know from the literature. I'm going to talk about how we measure as we're developing a system of care for the injured, what's the best way to measure if we're making an impact in that care. And then I'll talk some specific ideas about trauma care in low and middle-income countries. So I think you've seen all the data today. Really, there's greater than 5 million deaths per year, about 16,000 deaths per day. We don't really know how much a good trauma care system would impact that. Numbers vary, but we do know that even if our best preventative measures take place and are in place, we're still going to have some problems. Even in this country, as I spoke of yesterday, still 16% of Americans don't wear their seatbelts. So there's still going to be injured patients, still people going to be doing things that probably shouldn't be doing, and we need to have in place a trauma care system we can care for those patients. One thing to highlight, as you know, trauma does impact the people who are injured are usually the 19 to 44-year-olds, those individuals who are most contributory to society at large as far as their working years. So there's also a great economic impact when we talk about trauma care. We can look at trauma care in three different ways as one package. Pre-hospital system is that it takes place, and then here we know of that as the 911 system or ambulance system. There are both formal and informal systems throughout the world that do much the same. The hospital care is, of course, those individuals who arrive at an institution, stable or unstable, requiring some care. And then post-hospital care, and this would be more of the rehabilitation. In more detail, when we talk about pre-hospital care, we can divide that up into many different areas, but in broad strokes, we talk about communication systems. This proves to be a difficult place, particularly in low resource settings. Cell phones have helped with that. But with that, you need to be able to triage patients, have a system where patients are taken to the correct facility. You need to have some kind of transport, whether it be taxi, bus, rickshaw, or in more formal systems, ambulances with trained personnel, either BLS, EMT trained, or paramedic. And then, as I mentioned, you need to be able to triage these patients, get them to the correct facility. And there are protocols that drive this in functioning systems, where the patient should arrive first, where they should be taken subsequently for definitive care. Hospital can also be divided into many, but in broad strokes, talk about human resources. Are the personnel trained? Do they have the capabilities to care for these patients when they arrive? Are there people available in institution who can care for these patients? A neurosurgeon, orthopedic surgeon, a general surgeon, anesthesiologist? Is the infrastructure in place? Do they have equipment, x-ray machines, pins and rods for femur fractures? This kind of thing can be very difficult in low resource settings where maybe trauma patients aren't getting the priority that is needed. And then definitive care, and what I mean by that, is there someone there who can really take care of the patient if necessary? Can they go to the operating room, then go to the ICU, then get rehabilitation within the inpatient setting, resulting in their discharge to a rehab facility in the best possible circumstances? And then also like to combine with that rehabilitation, which is an important function. Our patients here at Johns Hopkins, and we may not be the model for all institutions, but my trauma patients are seen by physical therapy and occupation therapy the first day of their hospital stay. They get them out of bed, they get them moving, they're using a central spirometry. All these things are very important for functional long-term outcome. Having said that, our patients then go from here and if indicated, go to a rehab facility where they are also cared for. They are ambulated, they work on upper extremity if necessary for occupational health standpoint. These all ensure patients get the best possible care and the best possible outcome with their injury or trauma. So what is the evidence? The evidence I'm going to show you today is developed world evidence, but there's some pretty good data out there showing that trauma care systems do improve outcome. This is Nathan Avery's study that looked at effectiveness of state trauma systems, and he found that there was a 9% crude mortality improvement compared to those without trauma care systems. So we know that trauma care systems do have a function. Of course, Dr. McKenzie here at Johns Hopkins is well known here. I will tell you at trauma meetings, she's a rock star because she published this data, and trauma surgeons don't want to hear, they love to hear that. Trauma systems are important, and this is what she showed in her very large studies. She looked at effective trauma care systems, the mortality, showed an inpatient mortality rate was significantly lower in trauma centers, a lower one-year mortality rate, and it showed a risk of death was significantly lower. She also showed that it was cost-effective. Now, it's not to say that trauma care systems don't cost a lot of money, and we know this, and this is something we struggle as we try to improve the care of the injured in low-resource settings. It's not a situation where you can always just throw money at it. And then Charlie Mock is from University of Washington and has done a lot of the initial groundbreaking work in the 90s on trauma care in the developing world, specifically in Ghana, but in other areas, especially when he was at WHO and otherwise. And he has done many works, and if you're interested, I encourage you to look up his papers, really set the stage for this. But he has shown that there is a difference in care. This is an interesting paper only that it shows that as GNP increases per capita, the pre-hospital case fatality and serious injuries goes down. This would also, obviously, as people become more economically viable, communities, systems, that you can have a better functioning system, and thus patients have better outcomes. So what are the benefits of trauma care systems? And these are just kind of some of my thoughts as we try to convince people in low and middle income countries that they should put more effort, more funds toward trauma care systems. First and foremost, we argue that it would save lives. We understand that maybe we're not going to save the lives of the most severely injured. One of the things that's happened here in the United States is our systems become more complex. We are able to save higher and higher severely injured patients and actually bring them from the jaws of death. But in low-income countries, I think it's those middle ISSs, those middle severities that we are missing, that patients aren't even making it to the hospital, and when they get to the hospital are not receiving the care they require. If you develop an EMS system, you develop a framework. And through that framework, you have properly equipped ambulances, you have properly equipped personnel, you have faster and improved patient care. And really, if you get an EMS system work, not only are you impacting injury, trauma, you're impacting all facets of care. OBGYN, cardiac emergencies, surgical emergencies all have improved outcomes if you have an EMS in place. You also build capacity through trauma care systems. People get a better medical understanding of injuries and resuscitation. You have increased capabilities to treat patients. You have improved emergency medicine departments, improved trauma surgery departments, better orthopedics and neurosurgery departments if they learn to care for these patients. And you actually, through trauma care systems, and this is what's happened a lot in the developed world, is you get standardization of care. So there's protocols through all the multiple associations, both here and in Europe, that drive how each patient is cared for. And by doing such, you have better outcomes on a patient-by-patient basis. One thing also that trauma care can drive is better intensive care unit care. If you go into any unit of a level 1 center, a large percentage of their patients will be the sick trauma patient. They provide capacity, build capacity within that structure, give the nurses, the doctors, the technicians, the respiratory therapists, all improved abilities to care for the sickest of patients. And of course, this flows over into other areas of medicine and critical care. I also put blood transfusion protocols here. I think it's an important thing to point out that many of the institutions that we go to do not have any blood available. We, of course, have a very good network here in the United States that provides adequate or abundant blood for care of the patients. But this trauma is a large user of blood products within any system and can drive that protocol and that system. Trauma care also drives data. Now, this has been slow in coming, even here in the United States. We now have very good registries at most of the trauma centers in this country, but it was only when it was mandated by the American College of Surgeons recertification process that took place. So we understand that there's been obstacles both here, but as we go out, and I'll speak to this in a few minutes, data is extremely important in the work we do. It drives quality improvement, it drives patient care, it drives administrations to make the right decisions. Data is extremely important. And then any functioning trauma system must have a quality or performance improvement program. And there are many courses out there now that are excellent in teaching individuals, teaching systems how to care for patients and improve quality improvement. And the systems that the level 1 centers here in the United States have are impressive if you were able to participate in them as far as identifying systems issues without blaming specific individuals for lack of care. So if an individual comes in, has an untoward event, that event is studied, the system requirements that were missed are then studied and put in place, resulting in system changes. And there's whole courses on this. We could spend much time on one of our passions. So really, trauma care systems, I argue, do many things. Now, which of these things, obviously we want to save lives first and foremost, but we also want to decrease morbidity associated with trauma. We want to have more data, more QI. So how do we go about doing this? I first want to talk a couple minutes, and some of you have talked about this during our meetings this week. How do we measure that we're improving care of patients? One of the issues in our work and the places we go is that we want to show that we're improving the outcome of our patients, but we don't have the resources to go and completely redo a system. And so we have to figure out which way is best to measure. Our primary outcome would ideally be mortality if we could show an improved outcome, and it is a driving function, but that may not always be possible in the settings in which we're practicing or trying to improve care of the injured. Secondary outcomes such as ICU stay and hospital stay can also be measures, and these can be usually measured in most hospitals in the developing world, but again, they're surrogates for your mortality. And sometimes in the places we work, we have to look at other, such as pre-hospital care and hospital care, and this can be broken down even further. For instance, time of injury to arrival at the hospital is one of the metrics we have frequently used here in the United States and in other places we work in the developing world. We also can talk about availability of administration, of drugs, of bandages, pulse oximetry, and we do have some locations where we can show that these tertiary outcomes have been greatly improved. Unfortunately, making the link back to mortality can be difficult unless you have a sustained program or in these locations for quite some time and are able to collect a large number of patients where you can show that improvement. So I guess the questions for LMICs is, do trauma care systems save lives in LMICs? There are some data out there, even some recent papers that say, yes, that does improve lives. What should the trauma care system look like in these centers? And this is a question I struggle with. As I go to these different places, people want to put in the developed world system. They may debate whether they're putting the physician in the ambulance like the European model, or they're doing it more the US model where there's EMTs in the ambulances and the people who are receiving the patient at the hospital may be differently trained. But is that really the model that can work in LMICs? There are billions of people who are not receiving any care in the pre-hospital setting and very little care in the hospital setting to what we would consider to be a standard. So something that we should constantly be asking are we doing the right thing in developing a developed world model for the developing world? And then the question we always ask is, who are our stakeholders in trauma care? Are those the local EMTs, the local administration? We should always try to engage the administration leadership, but who should be our champions and push these through? One of the issues we have, of course, is lack of data. That data package is really growing. There's a lot more data out there, but in specific areas, specific countries, there may be no data. And so we feel that lack of data is a crucial stepping stone to really defining what the burden of injuries in these centers are and what impact care is. Just defining what the injury surveillance and injury demographics are is not enough when it comes to trauma care systems. You must look at patient outcome. You must follow them longitudinally, at least through their hospital stay, and ideally past that, if you're really going to see if the trauma care system is making an impact. So lack of data is really key, and if we can get better data, then we can help all these other things I've listed here, such as perceptions of care, lack of interventions, lack of financial support, lack of champions, all very important if we're going to be successful. So in the final few minutes, just want to talk about a few more items that are important in LMICs and some things that we have found to be successful and the challenges. Of course, I've talked about data. I say enhance trauma registries. Many times trauma registries really follow the patient through their hospital course in the traditional sense of the term. We try to integrate registries to capture not only hospital-based data, but also pre-hospital-based data, so that there's a continuity of that patient care, and allows us to see how the patient does throughout their care. What is their pre-hospital time? Did they receive care? What kind of care did they receive in the hospital? Harder than it sounds, and that's the reason many developed world systems don't have an integration between pre-hospital and hospital-based systems. Data on disability and rehabilitation would be great. Really hard to capture. And Dr. Petrani, one of my associates, does a lot of work in this area, and we're working on capturing more of that data, but of course, the number of patients we can capture is in the hundreds or thousands, not into the tens or hundreds of thousands. Of course, in low resource settings, all these things are difficult. There's a lack of infrastructure, a lack of documentation. One successful way of integrating registries is to be able to go back and look at the patient record, but if the patient record is inadequate and doesn't provide adequate data, it's very difficult to define what happened to that patient through their hospital stay. So then you decide, okay, I'm going to give more data collectors, I'm going to have more people working on this, but then you are using up a lot more resources, you're not making a sustainable model, so something we struggle with. It's really important to identify and promote inexpensive ways to build capacity. And this can be done in many different ways. Training and staffing is obviously something that the recipient enjoys and we enjoy doing. It does build capacity and trains the champions in this area. It also, another way you can do is build physical resources, and although this can be very costly, small purchases can make a big difference. Whether it be an inexpensive blood pressure cuff, a pulse oximeter, these things can make a difference in one institution and across a system. But understanding that a complete system is very expensive. If you are involved in an MVC here in Maryland, there's a fantastic system that was designed in the 70s. These helicopters are run by the Maryland State Troopers. They will be dispatched to pick you up. You will be brought to usually University of Maryland Shock Trauma, where you receive a very high level of care. Of course, this costing millions and millions of dollars a year, but a system that the people of Maryland decided they want. It's part of their taxation, and it provides an excellent level of care. This is Yaoundé, Cameroon. They have, with most centers, the ambulances are hospital-based, so they're dispatched when the individual causes the hospital use of many with means, who calls, the ambulance is dispatched. But in most cases, these ambulances are used for hospital-to-hospital-based transfer and not for any pre-hospital care per se. And this is something we see quite often. This is Naivasha, Kenya, where they may have an ambulance, but it's not functional. It's been sitting, and I've seen this ambulance in many different states of disrepair over the years. And then this is in Bangladesh, in the Matlab region, and this is their ambulance they use in one of their districts. So you can see that timely care might be more problematic for this patient. And then, of course, the actual hospital base, a typical resuscitation bay here in the United States, of course, again, costing millions of dollars a year to maintain, and then the resuscitation unit in Yaoundé, Cameroon, with no equipment. The patient's family have to go out and purchase the IV fluids from the street before the patient can be administered IV fluids. Most importantly, we need to involve key stakeholders. Identifying those key stakeholders may not always be evident, and it's difficult in many settings. And through these processes, we try to identify who these people are. They may not always be Ministry of Health, although you want ministry individuals involved in the process because that's where you can get legislative changes. Training programs we've already talked about. Really, you want to see if you can develop a pre-hospital system of some sort. It needs to be formal if possible for the reasons I spoke of earlier, meaning you need to have a universal number where people can call in. You need to have a triage system. And what we find happening is that there's these minor systems being set up. A special interest will set up a small ambulance service that serves a small part of the population, maybe an insurance firm within a certain district or country, but of course it's not serving the wider distribution of the population. Standardization is extremely important. I list a couple of the hospital-based courses here. ATLS is the one we use in the United States. PTC, primary trauma courses, used and free, available to all parts of the world. Of course, people work toward a different standard depending upon their location. But again, important to have standardization of care. We found in trauma that over and over standardization leads to improved outcomes in patient care. So if we can get policies in place, and I think my next talks about legislation, if we can get legislation in place that dictates standards of policy, then it can result in better patient care over the long run. So in summary, I think it's a really unique challenge in the developing world to develop trauma care systems. We find that there are many informal systems in place, but it's not really reaching the broad population for many reasons. There are public health reasons that's not occurring because it costs money. People don't have communication, don't have phones, don't have access. But we do know from the developed world that trauma care systems in a formal setting can work. As I've mentioned, though, we are still struggling to figure out what that informal setting should look like as we ramp up. Eventually, hopefully these countries will have a more formal setting. Whether that looks like our system here who will know? We need better data, and that's one of the things we do a lot of in the unit, injury unit, is try to collect data, analyze the data, present that to stakeholders, and we've been successful. We've presented to the Minister of Health in Cameroon, we've met with the Ministry of Health people in Kenya, and this continues to be one of our priorities, to try to make trauma care a priority on the public health agenda. And then I think I've already emphasized this, that each country and region requires a special emphasis and certain requirements based upon population requirements, traffic patterns. Many of us have a dear friend, Nobojit Roy, who lives in Mumbai, and he says you could never have an ambulance service in Mumbai. They would not get anywhere. And I told him that there was nothing that 20 helicopters wouldn't fix. But of course, he can't buy 20 helicopters. So there's many obstacles to having these kind of systems. And I've talked at length about stakeholder engagement. So I'm sorry for the late start, but thank you very much, and thank you for your attention.